Because if you don't have the political structures that support the HIV response, particularly the difficult decisions, how to give prisoners condoms in prison to stop the transmission of HIV, that's a really difficult decision politically. If you don't have that, you may not have a sustainable response. The fourth is structural, especially the health system. The fifth is programmatic, the skills to run large-scale programs for HIV and AIDS alongside other large-scale programs. And the sixth is human rights. And human rights becomes important because, as I said earlier, not everybody who's at risk of HIV is politically correct. As one politician put it, I don't get any votes for supporting the rights of men who have sex with men, commercial sex workers, and drug users. I don't get any votes. This was not a politician in Uganda. This was outside Uganda. So this topic of what are the rights, if any, of some of the groups who are most at risk is a human rights issue. But one thing is very clear. Every Ugandan has the right to health care, regardless. So if they don't have the legal right to have sex, they definitely have the legal right to get health care. So these 6 tenets, and let me repeat them: financial, epidemiological, political, structural, programmatic, and human rights, are put forward as a framework for sustainability, and you can measure how, as a country, you are performing. I would like to add a 7th, and that is about country capacity. Because you can have those 6 tenets, but you don't have the country capacity to implement them. Luckily, Uganda, compared to most other African countries, has developed very strong capacity in most of these areas, utilizing the strength of government and NGOs and communities in particular. So it should not be too difficult for Uganda to be sustainable in all 6, apart from this challenge of $500 million. I want to introduce a leadership concept that I have been teaching and mentoring leaders, particularly those who have succeeded me, and which we don't often think about. And that is managing success. Managing success is a good problem to have. And some of you may be saying, but if you're successful, what is there to manage? Well, we have seen a lot of people who are successful, in inverted commas, make a lot of money, and that success becomes a problem to them. I personally, now that I'm semi-retired, climb mountains to pass time. And often when you get to the peak of the mountain, that's success. But that success is useless unless you can come back down again. And that is what managing success is. And today, Uganda is challenged by a lot of success. We have a lot of success in the fight against HIV. It's a good problem to have, but we need to know how that success will create challenges. The first success is that we have 1 million people alive and on antiretroviral therapy, perhaps even 1.2 million. Lutaaya could never have imagined even 10,000 people being on treatment, but we now have almost 1.2 million. That's a tremendous success. Can we clap for that? That's a huge success. And thank God, because they are alive. They can be fathers, they can be mothers, they can be children, they can be grandparents. But managing that challenge is huge. The second is the challenge of building and maintaining a strong health system. And HIV funding in recent times has been very useful in contributing to building that health system. Which means that as much as it is a challenge for the minister, it provides a platform that other diseases and other conditions can be tackled. In particular, non-communicable diseases can easily be layered onto the platform for HIV and AIDS. The third success is that HIV prevention for adolescent girls and young women and young people is complicated. Uganda has made progress. Sometimes we look at the statistics, but if you look at where we are compared to South Africa, if you look at our HIV incidence and prevalence for young people, it's not good, but nowhere near as bad as South Africa. And it's very complicated to manage, but it opens doors for more comprehensive sexual and reproductive health education that in turn can help HIV prevention. The other success is that government of Uganda has learned how to work with tens of thousands of NGOs. And a big clap to the Uganda AIDS Commission for coordinating that big challenge. It's very unique. It's very unique. There are countries, in Botswana, there are only 10 NGOs that work in HIV, 10. Here, there are probably 10,000. But this success can be leveraged and translated to other areas like education, agriculture, and WASH. This unique partnership, unique success that Uganda has had. And of course, finding this $500 million is going to be a challenge. But if we put our heads together, if we innovate, if we think of new ways to raise funding, this is not just going to benefit HIV, but going to benefit a host of other problems. So let's move to epidemic control, the holy grail, which is defined quite simply here, eliminating new infections and ensuring all people living with the virus have access to the quality treatment and support services they need. And I want to highlight all people. It doesn't matter if, and I will use Reverend Gideon Biamugisha as an example, it doesn't matter what his personal views might be. Thank you. It doesn't matter what your personal views are about commercial sex workers, or even what the Bible says about commercial sex workers. If they are HIV positive and they need treatment and support services, we have a responsibility to get it to them. We need to separate our judgments on people's lifestyles from our responsibility as a society to care for each and every individual who is in Uganda. We need to make that separation in our minds. We were not born to agree with everyone on everything. I assure you that in this room, we all have sex differently and for different purposes. I assure you. I'm not going to do a survey, but I assure you that that is true. So, at a minimum, we need to separate this issue. What are my personal views? What does my church say? What are my moral views? From the issue that is at hand, which is we need all people living with the virus to have access to support and treatment. And in that regard, we are moving into an era of differentiated service delivery, a client-centered approach. An approach that says that not everyone is the same. Not everyone wants to get their treatment at 9 o'clock in the morning. Some people may prefer it at 9 p.m. at night. That young people may not want to come to a health facility. They may prefer to come to a youth center, and so on and so forth. And in my opinion, there are like 5 key groups when you're thinking of differentiated service delivery. The first are people who are newly diagnosed with HIV. They've just walked into a health facility, they've tested, and we are saying, now that you have tested positive, we want to start you on treatment today. That's a special group. When I took my first HIV test in 1989, it took 1 week to get the results because the technology in those days did not give you your results immediately. I can remember that week in great detail, I assure you. In great detail. I looked back in history, trying to remember what happened and so on and so forth. My wife Sheila is here, of course, saved me from HIV by getting married. In our case, marriage was protective, not the other one that I was talking about. Sheila, please stand up for recognition. They may not know you. So this first group who have just got an HIV result, and then you are telling them to start treatment for life, we need to understand what type of service delivery do they need. Because I don't think we are giving them the right package of services. We are in such a hurry to start the treatment that perhaps the counseling, the support services, the tracing services are not to the quality that they should be. The second group are stable, virally suppressed HIV positive in chronic care. They are fairly stable. They don't even want to come to your clinic every month. Perhaps not even every 3 months. Maybe they want to come every 6 months. The third group are young people who are HIV positive. All the data, not just in Uganda, is showing that young people are least likely to be drug adherent. They are more likely to be lost to follow-up. And so a special intervention for young people is important. The fourth is, of course, pregnant women and breastfeeding mothers who are HIV positive, because you are having 2 individuals, sometimes 3 if they are twins, maybe 4 if they are triplets, and needs a special package. And the fifth are key populations. Now, when we say key populations, of course, the things that come to mind first are men who have sex with men, commercial sex workers. But there are other key populations that we don't often mention. One has got an acronym, MMM. Who has heard of MMM? MMM. Dr. Watiti, of course, I'm sure you have heard. Mobile men with money. Mobile men with money. Truck drivers, fisher folk, and other men who are mobile and have money to spare, because that money is often spent on alcohol and soon thereafter on sex. Prisoners are a special population. If you look at the HIV prevalence of prisoners, it's about 17%. People with disabilities are key populations. If you look at the latest data on people with disabilities in Africa, HIV prevalence is double that of the general population. And there are reasons for that, which I won't go into. But in my view, differentiated service delivery is going to be a learning curve for ministries of health, not just Uganda. Because government, rightly so, is trying to integrate HIV services into primary health care because it's more efficient. But if you're going to do differentiated service delivery, now you have special services for special people and need special skills. And so sustainability has got to require a dialogue between Ministry of Health, NGOs, to see who will help out in providing a differentiated service delivery approach. For sustainability, we also need efficiency, because there is wastage in the system. And if we achieve efficiency, we will save money. And if we save money, we will serve more people. So therefore, we need cheaper HIV drugs. But remember what I said, even if the drugs cost nothing, supposing the price of the drugs was nothing, that would only take $75 off perhaps $300 or $350. And that money still needs to be found. Do you know that today, and I cross-checked this, the cost for lab monitoring of someone who's HIV positive is more expensive than the drugs that they swallow? Let me repeat that. Today in Uganda, the cost of monitoring, laboratory monitoring of someone who's HIV positive costs more than the drugs that they swallow because of the cost of viral load. So that is where we perhaps could get efficiencies. We need treatment protocols that reduce the interaction between the health system and patients. We need to use more volunteer services, which means we need to value community-based organizations and faith-based organizations and organizations of people living with HIV and AIDS. There's a whole host of things that we need to do if we are going to achieve efficiency. Let me now move to what could be very controversial. And I need you to listen carefully, because I don't want this to become another stigma that I am a virus reservoir. Scientifically, we know 2 types of reservoir. If you're an HIV positive person and you are on treatment and you get virally load suppressed, that doesn't mean the virus has been completely eliminated from your body. There are some places in the body where that virus is hiding, and if you stop treatment, the virus will come back again. That's the virus reservoir in an individual. But there is what I'm now calling the virus reservoir in the community. These are individuals, for whatever reason, who don't have viral load suppression, either because they don't even know they're HIV positive, or they know they're HIV positive, but they are not swallowing the medicines. And unless we tackle this community viral reservoir, it has the potential to flare up again. And that's why Epidemic Control seeks to suppress the virus in every individual who's HIV positive. Let's remember, HIV is caused by a virus. HIV is not caused by people or people's behaviors. If there are 10 of you and you are all HIV negative, you can have as much sex as you want with each other, 10 times a day if you want, you will never get HIV. You need the virus to get the disease. But this is a clever virus because it has adapted to people's behavior to take a ride and infect others. And as I said earlier, we now know scientifically that U equals U. Undetectable is untransmissible. And so we need to find the virus wherever it is. In particular, to make sure that we test people who don't know that they're HIV positive early so that they can go on treatment. To look for those who are non-adherent, because when they're not taking their drugs, their viral load will climb again. Sometimes it becomes resistant to the drugs that they have been taking. And especially people who have converted recently, therefore partner identification and finding becomes an important activity for programmatic sustainability. And this issue of key populations who often have high HIV prevalence and low use of HIV services. So let me talk about this key and priority populations, because they are both at high personal risk. They are potentially a viral reservoir if they are not on treatment, and therefore can bridge to generalized epidemics. This is being seen in the United States, where a lot of these key populations, whether they're using drugs, whether they are men who have sex with men, whether they are any of the other categories, have sex in 2 or 3 different populations and form a bridge. And they are characterized by both high HIV prevalence and high incidence, and often poor access to HIV services. So this is the irony, that you have a high HIV prevalence, high incidence, but you are afraid to go to the health service because you are afraid what questions might be asked. You are afraid that you will be discriminated and stigmatized. And this is a real issue. And so we need to figure out, how do we take services to commercial sex workers, men who have sex with men, mobile men with money, discordant couples, adolescent girls and young women, prisoners, people with disability, and fisherfolk. And the big challenge is, this is not a homogeneous group. People with disability may have nothing at all in common with commercial sex workers. And each group has its own stigma, by the way, a specialized stigma. People with disabilities are stigmatized. Commercial sex workers are stigmatized. And so when you lump everyone into key populations, person with disabilities say, I don't want to be in that group. That group also has commercial sex workers and men who have sex with men. Me, I'm not like that. So it's complicated. I'm not giving an answer, by the way. I am saying it's complicated. And yet, if we don't figure out how to take services to these key populations, that viral reservoir will grow, and it will make it difficult to completely eradicate the epidemic. And some of these groups are very, very challenging for government because they are intrinsically illegal. This week, there was an article in the newspaper where the Commissioner for Prisons admitted that giving condoms to prisoners can't happen because it is illegal in this country for a man to have sex with another man. So, since you're giving condoms in a male prison, it's for what? Even though he understood the need, but your hands may be tied. But there are other ways to tackle that problem if we think innovatively. If every prisoner had an HIV test regularly, and all those who were positive received antiretroviral therapy and had a viral load that was undetectable, then in prisons we would have achieved U equals U. So, HIV prevention, 2020 and beyond. This field of HIV prevention has pessimists as to whether it will work, proponents of particular approaches, and hopefully pragmatists who understand that combination prevention is the way to go. And I think I'm a pragmatist. And what I want us to focus on is not so much behavior as safer sex, and understand in your context what is safer sex. So below the age of 18, safer sex is no sex. Safer sex, no sex. You don't have sex. But above 18, what does safer sex mean? Might mean condoms. It might mean PrEP. It might mean serosorting. Serosorting is where you do an HIV test on each other just before you have sex. There's a whole range of interventions that can give you safer sex. There's another lecture I give called the A to Z of HIV prevention. A to Z. It's not just ABC. There's something for every single letter of the alphabet. The biggest challenge for sustainability of HIV prevention is that we don't have anything that is 100% efficacious in real life. You will see figures that PrEP is 99% efficacious, but that is in a clinical trial. In real life, people forget to swallow their medicines. And so how do we use partially efficacious technologies like condoms, like male circumcision, like PrEP, and soon, hopefully, a microbicide ring? How will we message? How will we explain to people that because circumcision is not fully efficacious, you also need to put on a condom? These are challenges that Uganda has to tackle if we are going to sustain our HIV prevention agenda. So let me get to my favorite slide. No, this is not my favorite slide, but it reminds us that if we don't turn off the tap of new infections, we are going to continue having a huge and bigger burden. So prevention is really, really important. So this is my favorite slide, this one. Sex is a currency that buys prosperity for some, it buys pleasure, and it buys posterity through procreation. That sounds very poetic, doesn't it? So we should not underestimate sex. Can you imagine an activity that gives you prosperity, that gives you pleasure, and also gives you posterity? Abasika, those who will live after you. Sex is powerful. Some of our programming that we say safe sex, and Dr. Kware will remember zero grazing. Zero grazing worked when people were seeing others dying, when the epidemic was in your face. Today, when is the last time any of you walked in the streets and saw someone with end-stage AIDS. It's not there. Thank God it's not there. So it's a currency that is used not just by commercial sex workers, because sometimes sex is a currency, it means you're selling sex. Not at all. The general population also uses sex as a very powerful currency. Married couples use it, and I don't mean literally cash, but it's a very powerful currency. It's been there since before organized religion and most civilization. The exchange rate, you got to exchange dollars. The exchange rate of sex varies, but there will always be buyers. I guarantee you, there will always be buyers. And it's something we rarely talk about. Very rarely, especially with our children. I remember our daughter coming to our bedroom once to ask, she wanted to sleep in our bedroom with us. And we told her no. She was around 8 or 10. And so she went back and spoke to her older brothers. And I think they told her that, mommy and daddy have sex. I don't know what they explained, but they probably told her that. So she came back to us, got her mattress, and said, okay, I've gone to my room. Then as she got to the door, said, good night, daddy and mommy. Have fun. She was 8 or 10. We don't want to talk about sex. But if we are going to be sustainable in our efforts for HIV prevention, especially for young people, we are going to reboot our computers and find ways to talk about sex so that we can influence safe sex.